This video is about micturition. Micturition is the process by which the urinary bladder empties when it becomes filled. This involves two main steps. First, the bladder fills progressively until the tension in its walls rises above a threshold level. This elicits the second step, which is a nervous reflex called micturition reflex that empties the bladder, or if this fails, at least cause a conscious desire to urinate. Although the micturition reflex is autonomic spinal cord reflex, it can also be inhibited or facilitated by centers in the central cerebral cortex or brainstem. Physiological anatomy of the bladder. The urinary bladder is a smooth muscle chamber. It's a smooth muscle chamber composed of two main parts: the body, which is the major part of the bladder in which the urine collects, and the neck region, which is a funnel shaped extension of the body, passing inferiorly and anteriorly into the urinogenital triangle and connecting with the urethra. The lower part of the bladder neck is also called posterior urethra because its relation to the urethra. The smooth muscles of the bladder are called detrusor muscles. Detrusor muscles. Its muscle fibers extend in all directions and when contracted can increase the pressure in the bladder to 40 to 60 mmHg. This contraction of the detrusor muscle is a major step of emptying the bladder. Contraction of the detrusor muscle is a major step in emptying the bladder. Smooth muscle cells of the detrusor muscle fuse with one another so that low resistance electrical pathway exists from one muscle cell to the next. Therefore, an action potential can spread. Low resistance electrical pathway exists from one muscle cell to the other. Therefore, an action potential can spread through the detrusor muscle from one muscle cell to the next to cause contraction of the entire bladder at once. On the posterior wall of the bladder, lying immediately above the bladder neck, is a small triangular area called trigon. At the lowermost apex of the trigon, the bladder neck opens into the posterior urethra, and the two ureters enter the bladder at the uppermost angle of the trigon. The trigon can be identified by the fact that its mucosa, the inner lining of the bladder, is smooth in contrast to the remaining bladder mucosa, which is folded to form rugae. Each urethra, as it enters the bladder, courses obliquely through the detrusor muscles and then passes another 1 to 2 cm beneath the bladder mucosa before emptying into the bladder. The bladder neck posterior urethra is 2 to 3 cm long, and its wall is composed of detrusor muscle interlaced with a large amount of elastic tissue. Elastic tissue is also there. So the muscle in this area is called the internal sphincter. Internal sphincter. Its natural tone normally keeps the bladder neck and posterior urethra empty of urine and therefore prevents emptying of the bladder until the pressure in the main part of the bladder rises above a critical threshold. Beyond the posterior urethra, the urethra passes through the urinogenital diaphragm, which contains a layer of muscles called the external sphincter of the bladder. External sphincter of the bladder. This muscle is a voluntary skeletal muscle. Voluntary and skeletal muscles. Skeletal muscle in contrast to the muscle of the bladder body and bladder neck, which is entirely smooth muscle. The external sphincter muscle is under voluntary control of the nerve system and can be used to consciously prevent urination even when involuntary controls are attempting to empty the bladder. Then, innervation of the bladder. The principal nerve supply of the bladder is by way of the pelvic nerves, which connect with the spinal cord through the sacral plexus, mainly connecting with the cord segments S2 and S3. Coursing through the pelvic nerves are both sensory nerve fibers and motor nerve fibers. The sensory nerve fibers detect the degree of stretch in the bladder wall. Stretch signals from the posterior urethra are especially strong and are mainly responsible for initiating the reflexes that cause bladder emptying. The motor nerves transmitted in the pelvis nerve are parasympathetic fibers. These fibers terminate on ganglion cells located in the walls of the bladder. Short postganglionic nerves then innervate the detrusor muscle. In addition to the pelvic nerves, two other types of innervations are important in bladder function. Most important are the skeletal motor fibers transmitted through the pudendal nerve to the external bladder sphincter. These fibers are somatic nerve fibers that innervate and control the voluntary skeletal muscles of the sphincter. Also, the bladder receives sympathetic innervation from the sympathetic chain. From the hypogastric nerves, pudendal and hypogastric nerves, connecting mainly with the L2 segment of the spinal cord. The sympathetic fibers stimulate mainly the blood vessels and have little to do with bladder contraction. Some sensory nerve fibers also pass by way of the sympathetic nerves and may be important in the sensation of fullness and in some instances pain. So when we try to learn about the innervation of urinary bladder, we could see regions like sympathetic nerve, parasympathetic nerve, and pudendal nerve, ureter, body, trigone, bladder, neck, posterior urethra, and external sphincter, etc. are seen. Then anatomy of urinary bladder in males and females, you could see in case of female, ureters are there, ureteric openings, internal sphincter, ureteric openings, internal sphincter, urinogenital diaphragm including external sphincter, urethra, diaphragm muscle, trigone, prostate gland, bulbourethral gland, and external urethral opening. Bulbourethral gland, prostate gland, trigone, diaphragm muscles in case of male, and ureteric opening is a common one. Ureters are common. Internal sphincter is a common part in both female and male. They are present there. The urinogenital diaphragm including external sphincter and urethra. Transport of urine from the kidney through the ureters and into the bladder. Urine that is expelled from the bladder has essentially the same composition and fluid flowing out of the collecting ducts. There is no significant changes in the composition of urine as it flows through the renal calyces and ureters to the bladder. Urine flowing from the collecting ducts into the renal calyces stretches the calyces and increases their inherent pacemaker activity, which in turn initiate peristaltic contractions that spread to the renal pelvis and then downward along the length of the ureter, thereby forcing urine from the renal pelvis towards the bladder. In adults, the ureters are normally 25 to 35 cm long. The walls of the ureters contain smooth muscles and are innervated by both sympathetic and parasympathetic nerves, as well as by intramural plexus of neurons and nerve fibers that extend along the entire length of the ureters. As with other visceral body muscles, peristaltic contractions in the ureter are enhanced in parasympathetic stimulation and inhibited by sympathetic stimulation. The ureters enter the bladder through the diaphragm muscle in the trigone region of the bladder. Normally, the ureters course obliquely to several centimeters through the bladder wall. The normal tone of the diaphragm muscle in the bladder wall tended to compress the ureter, thereby preventing backflow or reflux of the urine from bladder. When pressure builds up in the bladder during micturition or bladder compression, each peristaltic wave along the ureter increases the pressure within the ureter, so that region passing through the bladder wall opens and allows urine to flow into the bladder. In some people, the distance that ureter passes through the bladder wall is less normal, and thus contraction of the bladder during micturition does not always lead to complete occlusion of a ureter. As a result, some of the urine in the bladder is propelled backward into the ureter, a condition called vesicoureteral reflex. Such reflex can lead to an enlargement of the uterus, and if severe, can increase the pressure in the renal calyces and structure of the renal medulla, causing damage to these regions. Pain sensation in the ureters and the ureterorenal reflex. The ureters are well supplied with pain nerve fibers. When a ureter becomes blocked or by urethral stone, intense reflex constriction occurs, which is associated with severe pain. Also, pain impulses cause a sympathetic reflex back to the kidney to restrict the renal arteries, thereby decreasing urine output from the kidneys. This effect is called ureterorenal reflex. And it is important for preventing excessive flow of fluid into the pelvis of the kidney with a blocked ureter. So, filling of the bladder and bladder wall tone, the cystomitogram. there is no urine in the bladder, the intravesicular pressure is about 0, but by the time 30 to 50 ml of the urine has collected, the pressure raises to 5 to 10 centimeter water. Additional centimeter of water. So additional urine 200 to 300 ml can collect with only a small addition raised in pressure. This constant level of pressure is caused by intrinsic tone of the bladder wall itself. Beyond 300 to 400 ml, collection of more urine in the bladder causes the pressure to rise rapidly. And superimposed on the tonic pressure changes during filling of the bladder are periodic acute increase in pressure that last from a few seconds to more than a minute. The pressure peaks may arise only a few centimeters of water or may rise to more than 100 centimeters of water. These pressure peaks are called micturition waves in the cystometrogram and are caused by the micturition reflex. Micturition reflex referring, so one can see that the bladder fills many superimposed micturition contractions. Micturition contractions begin to appear. They are the result of structure reflex initiated by sensory structure receptors in the bladder wall, especially by the receptors in the posterior urethra. When this area begins to fill with the posterior sensory structure receptors in the bladder wall, especially by the receptors in the posterior urethra, when this area begins to fill with urine at the higher bladder pressures. Sensory signals from the bladder structure receptors are conducted to the sacral segments of the cord through the pelvic nerves and then reflectively back again to the bladder through the parasympathetic nerves fibers by way of some other nerves, and the bladder is only partially filled. This micturition contraction usually relaxes spontaneously after a fraction of a minute. The retractor muscles stop contracting. And the pressure falls back to the baseline. As the bladder continues to fill, the micturition reflex become more frequent and cause greater contraction of the detrusor muscle. Once a micturition reflex begins, it is self-regenerative. That is, initial contraction of the bladder activates the structure receptors to cause a great increase in sensory impulses from the bladder and posterior urethra, which causes a further increase in reflex contraction of the bladder. Thus, the cycle is repeated again and again until the bladder has reached a strong degree of contraction. Then, after a few seconds to more than a minute, the self-regeneration begins to fatigue and regenerative cycle of the micturition reflex ceases, permitting the bladder to relax. Thus, the micturition reflex is a single complete cycle of the progressive and rapid increase of pressure, a period of sustained pressure, and a return of the pressure to the baseline. 1 minute. Progressive and rapid intense increase of pressure. Then a period of sustained pressure, return of the pressure to the basal tone of the bladder. Hence, the micturition reflex has occurred but has not succeeded in emptying the bladder. The reverse elements of this reflex usually remain in an inhibited state for a few minutes to 1 hour or more before another micturition reflex occurs. As the bladder becomes more and more filled, micturition reflex occurs more and more often and more powerfully. Once the micturition reflex becomes powerful enough, it causes another reflex which passes through the pudendal nerves to the external sphincter to inhibit it. If this inhibition is more potential, the brain, then the voluntary constriction signals. Once the micturition reflex becomes powerful enough, it causes another reflex which passes through the pudendal nerves of the external sphincter to inhibit it. If this inhibition is more potent in the brain than the voluntary constrictor signal to the external sphincter, urination will occur. If not, urination will not occur until the bladder fills still further and micturition reflex become more powerful. Then facilitation or inhibition of micturition by the brain. The micturition reflex is an autonomic spinal cord reflex. We know. Just learn that. But it can be inhibited or facilitated by centers in the brain. The centers include strong facilitative and inhibitory centers in the brainstem located mainly in the pons, and several centers located in the cerebral cortex that are mainly inhibitory but can be excitatory. The micturition reflex is the basic cause of micturition, but the higher centers normally exert final control of micturition as follows. The higher centers keep the micturition reflex partially inhibited except when micturition is desired. The higher centers can prevent micturition even if the micturition reflex occurs by tonic contraction of the external bladder sphincter until a convenient time presents itself and it is time to urinate. The cortical centers can facilitate the sacral micturition center to help initiate the micturition reflex and at the same time inhibit the external urinary sphincter so that urination can occur. Voluntary urination is usually initiated by the following. First, a person voluntarily contracts his or her abdominal muscles, which increases the pressure in the bladder and allows extra urine to enter bladder, neck, and posterior urethra under pressure, thus stretching their walls. This action stimulates the stretch receptors, which exerts the micturition reflex and simultaneously inhibits the external urethral sphincter. So, the action stimulates the stretch receptors, which excites the micturition reflex and simultaneously inhibits the external urethral sphincter. Ordinarily, all the urine will be emptied and rarely more than 5 to 10 ml left in the bladder. Abnormalities of micturition. A tonic bladder and inconsistence caused by detressor of sensory nerve fibers. Micturition reflex contraction cannot occur if the sensory nerve fibers from the bladder to the spinal cord are destroyed, thereby preventing transmission of stretch signals from the bladder. When it happens, a person loses bladder control despite intact efferent fibers from the cord to the bladder and despite intact neurogenic connections within the brain. Instead of emptying periodically, the bladder fills to capacity and overflows a few drops at a time through the urethra. This occurs as overflow inconvenience. A common cause of atonic bladder is crush injury to the sacral region of the spinal cord. Crush injury to the sacral region of the spinal cord. Certain diseases can also cause damage to the dorsal root nerve fibers that enter the spinal cord. For example, syphilis can cause constrictive fibrosis around the dorsal root nerve fibers, destroying them. This condition is called a tapes dorsalis, and the resulting bladder condition is called diabetic bladder. Then automatic bladder caused by spinal cord damage above the sacral region. If the spinal cord is damaged above the sacral ganglion region, but the sacral cord segments are still intact, typical micturition reflex can still occur. However, they are no longer controlled by the brain. During the first few days to several weeks after the damage to the cord has occurred, the micturition reflex are suppressed because of the state of spinal shock caused by the sudden loss of facilitative impulses from the brain stem and cerebellum. However, if the bladder is emptied periodically by catheterization to prevent bladder injury caused by overstretching of the bladder, the excitability of the micturition reflex gradually increase until typical micturition reflex return. When periodic but unannounced bladder empty occurs, some patients can still control urination in this condition by stimulating the skin of the genital region, which sometimes elicit a micturition reflex. Then an uninhibited neurogenic bladder caused by lack of inhibitory signals from the brain. Another abnormality of micturition is the so-called uninhibited neurogenic bladder, which results in frequent and relatively uncontrolled micturition. This condition derives from partial damage in the spinal cord or the brainstem that interrupts most of the inhibitory signals. Therefore, facilitative impulses passing continuously down the cord keep the sacral centers so excitable that even a small quantity of urine elicits uncontrolled micturition reflex, thereby promoting frequent urination.